There we go. All right. So, we kind of introduced viruses, kind of gave a little background in the last couple of lectures before spring break. Now we're going to get into the families. So each day from here in, we'll do a family of viruses. We'll give a little overview of what their description is, then we'll go into detail about them and if somebody has them and who gets them and when they get them and how we diagnose them and how all that works. Okay, so this is, I guess, the biggest thing when a year ago was we didn't really have a way of detection, an ID. Like, did the patient have this COVID-19 virus? Did they? And that was part of the first problems. So since it was a new virus, there weren't any, hey, every lab has this, every health department has this. So what you're going to see is some stories about, where these come from and how we go about detecting them. And we took it for granted. We thought it was going to be easy, just like, oh yeah, we'll know if somebody has, this virus because they'll produce antibodies against it because we do antibody testing for a lot of our viruses, right? Or we can do antigen testing. So like flu virus, we'll just do that. So all of that was in place, but when there's a new virus, those things weren't. We had to kind of switch gears and try to develop new tests. So that's where the PCR started, was, hey, we can do PCR testing now that we know the genome of the virus. So that was kind of first steps. So, I guess in years past when we did these lectures, it was just kind of like taken for granted that we knew all this would be fine, everything would work out. And we had to watch the testing not be there, testing get developed, people blasting on Facebook about how bad the testing was, like how can you put a test out that only catches 60% of the patients with it and that kind of stuff. So going through a lot. So hopefully this will switch gears just a little bit, switch us back to kind of a historical view with viruses and make you feel a little bit better about there are some other viruses out there. So adenoviruses and herpesviruses is where we're going to go today. So we'll start with the Adenoviridae family of viruses. So how do we define viruses? We kind of got that in the introduction. Like how do we put them in groups? So characteristic is how we do that. So if you see non-enveloped, icosahedral, double-stranded DNA virus. So that's kind of, every virus is going to have that kind of line of ID or their characteristics that we're going to put them in a group with. So with adenoviruses, self-limiting respiratory. So these are always fun to see when you hear self-limiting, which means is that what? You're going to get over them. You're not going to have them forever. They can also be respiratory. They can be ocular, so we can get them up in our eyes. And we can have GI tract problems, so gastrointestinal disease. So very common, because by the time you were 5 years old, there was a 3 out of 4 chance you'd already had an adenovirus and you possessed antibodies against them. So that's what, we go through this our lifetime of every year that we're on Earth, we're exposed to new viruses and we develop our antibodies against them. So it keeps reinfection down if we get exposed to it later. So if 75% of the population's already had it, got antibodies to it, who's at risk? And that would be children under 5. So if you haven't been exposed by 5, every year that you don't get exposed, you're at risk. And then I love this, the military recruits are also, and we'll see what that means in just a second. So transmission, with military recruits, anybody in the military, been in the military? Why would that be, what's up with military recruits? What does that mean? What is y'all's take? I mean, you're now becoming virologists. You're already epidemiologists. You're already immunologists. You're almost microbiologists, right? So What does transmission in a military recruit versus young kids? What does that mean? Why would a military recruit have an issue? Rarely fatal, wintertime, respiratory illness via respiratory aerosols.
Would it be because they're like the lack of space, like a bunch of people are like packed together?
Packed together, it's good, like that, yeah. Anybody else?
Just their living conditions in general. Right?
Living conditions in general. Okay. What else? So you see serotype 4, infants and young children, serotype 2. And then, of course, immunocompromised patients, we understand that because you're immunologists now with neonates transplant. What about just travel, right? No? Maybe? Exposed, what we're seeing, right? Getting exposed. Like, think about the, spread of this new virus. It took less than a year, all right, to basically be pretty much every point that we know on Earth, right? And it didn't take a year. So travel to new places. That's what I thought when I read military recruits. Yeah, it may be like new military, hey, we're gonna put you in and we're gonna send you over to some place and plop you down, and you're gonna have to go into communities and be community police and that kind of thing, and you're gonna be exposed to new respiratory illnesses. So I would think tourists too, but in a sense of a big group of people, I would say yes, military. So here is a tragic story. I know you'll love these. Tragic story of one of our early on Adenoviruses. Still, look, 2018. Tragic story of a college student. All right. So here we are. We're going to scare you now. Olivia Horrigold from Howard County, Maryland, was early in her first semester when she developed a cough, which later worsened to pneumonia. She died in November, Johns Hopkins Hospital, from an adenovirus, which caused her respiratory problems. She died less than 3 weeks after school learned of her illness. 5 more students had the illness tied to the same rare virus. So the reason I had you go down that military recruit issue is what? Kind of the same thing with college freshmen, right? Throw you in a dorm, send you into a community bathroom. I don't know about the guy. I know the guys' dorm where I went, there was 1 bathroom on our wing. So there was about 10 rooms or 12 rooms that used the same bathroom. We had a sink, but everything else, the shower and the bathroom, were down in the hallway. We all had to share, right? So I don't know about your graduation gifts, but mine came with a little basket from all my little toiletries I had to carry down the hall every day to the bathroom, whether it be for a shower or other things. No? They're better living conditions here? Nobody lived in the dorm their first year here? How were they? They good? Did you get sick?
Yes.
You did?
All in the shower.
Mold in the showers? I mean, splash a little bleach in there and fix that. What else? You know what, you get any respiratory illnesses? Anybody recommended your family doctor at home recommend you get the pneumonia vaccine before you came to school? Because you're about to go into a large living area of people from all over. No? Y'all think about it, or y'all just show up and go, hey, I'm here? Everybody's healthy, right? All right, so how do we check for adenoviruses? We do throat swabs. You're used to hearing that by now. Nasal washings, conjunctiva, and feces. So we have all different ways of finding it. So it could be in the GI, remember GI tract, respiratory, and even ocular. direct exam, electron microscopy. Well, we know that, you know, our little student health center over here does not have an electron microscope. I'm going to bet money on that. So we're going to use immunofluorescence. Maybe they have a fluorescent scope, but I doubt that too. So what are we going to do? We're going to send it to you after you get graduated, and you're going to be sitting in a reference lab working and taking in all these samples daily and checking them, right? You hope, right? Oh, that was the picture. If we had the electron microscope, we could see them. So that's the real virus. Here's a rendition, artist rendition. Kind of looks familiar to what we've seen a lot of pictures of lately, which is a spike, right? Part of the capsimer coming up here with the spike on top, viral capsid, number 2, so right here. Icosahedral, right, but not enveloped. So you got these spikes. And then linear, see this linear here, double-stranded DNA. It's awesome. Right, so now we kind of go back, think about the question I gave you for spring break. Living or dead? Viruses. Are they just a vector? Are they just a carrier of the DNA, or they have their own DNA? They have their own DNA, right? Herpesviridae. So these are some that you hopefully are familiar with somewhat. Not that you have them, but you probably do. But these are the ones that, you know, as we grew up as adolescent teenagers, right? There was always, I won't say always, well, I will say always. There was always somebody during the year that would have an outbreak, right? And it may be a cold sore. Oh, I don't know where this came from. I don't know why I have it on my lip. And there may be worse cases. It was just, I won't tell the stories, but like, what is wrong with your lips? Like, well, I went on a date with somebody last weekend, and evidently she had herpes, or he had herpes, right? So it spread from person to person, close contact. So we do have some bad stories in here too, but for the most part, we are familiar with these. We got herpes simplex virus, so we see that as HSV. What does the HHV1 out there mean? What does that stand for? I know that probably stands for herpes virus, but what's that extra H for? See how awake you are after blood bank lecture today. Human, thank you. Human herpes virus, number 1. Humans herpes virus. So we can have non-human herpes viruses too. So that's what I want to make the point. We see some of them familiar after 1 and 2. We see definitely some familiar ones here. We see number 3 is actually varicella for chickenpox, and zoster for shingles. There is a dash in there. Let's help you out with that. And then there's Epstein-Barr, right? I don't think we separate that into Epstein and then a separate bar, but we call it Epstein-Barr. We're familiar with that from immunology. And then cytomegalovirus, which hopefully blood bank covers sometime this semester. I don't know if she's covered it yet, but with things we need to think about with our blood supply, and why we need to make sure we have a negative CMV unit in-house sometimes for certain patients. I've covered that stuff yet. Don't know, don't remember. Y'all don't remember cytomegalovirus being in blood bank yet? Okay, it's coming, I'll say that. All right, these are enveloped when they have an envelope. They're icosahedral in shape with their capsid, and they're double-stranded DNA viruses. So again, they get put in the family of double-stranded DNA viruses. So quite a big group here that we're going to cover. Because they keep coming. Number 6, we see number 7 and number 8. And number 8, if you've gotten into HIV and you were paying attention when we did HIV, Kaposi sarcoma is associated with 8. So we're going to go through all of those. So we'll start. So here is herpes B. Naturally infects Asian monkeys. And so do y'all know that Dr. Walsh used to work in a monkey lab? Did y'all know that? Y'all didn't know that about, she hadn't divulged that? She was just sharing some stories the other day. And so one of her first jobs was working in the research monkeys. So what reminded me of that is that if you're working with live monkeys that have herpes simia, that a monkey bite could be transmitted to humans. And you see it's highly fatal for humans to get this 85% mortality. So if you're working with kidney cell cultures in research with monkeys, you have to be aware of this and make sure that the monkey does not have herpes simia and definitely don't want to get bit by the monkey. The good thing about herpes family, ether, chloroform inactivate the virus. So we can clean areas, detergents, quaternary ammonia, drying and it activates the virus, the enveloped virus. Persistent infections, we know this because we can't really get rid of, we can control, but we can't get rid of herpes viruses. And we know that with which one? Varicella-Zoster, because we know it just never really goes away. So they persist throughout your lifetime. Keep that in mind. So how do they do that? They have a latent stage. The viral DNA gets incorporated into your host cell chromosome, where it's replicated with the host chromosomes during cell division. There's no pathogenicity unless the virus is reactivated and begins a lytic stage where it starts to multiply, kills the cell, starts to invade other cells, and you get a reoccurrence of the viral infection. That should sound familiar. I think you've heard this before. And we see that with herpes simplex virus and varicella-zoster virus. There's a latent stage in the nerve tissue, is where those go. The cytomegalovirus and the Epstein-Barr go into the lymphoid tissue. So those are two separate areas of where they go hang out and lie dormant until they reactivate. So usually around finals week, stress builds, and we like to say that, okay, the herpes simplex virus reappears. That's what causes cold sores. And we have a breakout around our lips because of the stress that we're under. Once we reach a certain age, like 60 years old, we'll see that in a little bit with zoster, is that may reappear as a shingle. Cytomegalovirus, we got to be careful there because we see that with immunocompromised, okay, with patients that get cytomegalovirus, kids born to non-immune mothers. It's definitely an issue with cytomegalovirus. And then Epstein-Barr has been linked to a host of other things. So we're going to see that. So reactivation, if it happens, and subsequent secondary disease may either be symptomatic, meaning it has clinical signs, or asymptomatic when it's subclinical. You don't know that you regularly had a reactivation. So let's take a look at herpes simplex viruses. Remember we broke those down. So the disease now suspected to have, this was way back in Hippocrates. And I can't say Hippocrates without thinking about one of my former teachers that passed away to COVID after taking a vacation to Italy. Because I was in there and I would say Hippocrates in her classroom and it would drive her bananas. So she started calling me Clayude, taking my name apart like I did Hippocrates there. And I said, well, I have to say it that way to spell it like I've done for, in lecture with you guys. So anyway, this just brought up memories of like 9th grade history class. But a Greek physician actually described it back in BC, like 470 to 360 BC. That was his life. But it's also been, it was first isolated, which means that we kind of had an idea that there was something going on with people way back when. But it was first isolated in 1919 from oral and ocular lesions. So actually started isolating it about 100 years ago. In 1961, the virus was differentiated into its two serotypes, 1 and 2. They differ serologically, biologically, biochemically. They do share cross-reacting antigens, which you would expect, but they also have their own type-specific antigens. Their DNA sequence also differs, and it differs. 80 different strains have been detected, and possibly hundreds or thousands exist. So as you start to hear what today and this week, the variants, right? Heard variant strains. That's become common vocabulary this month. The British variant, all right, of the new COVID-19 variant is gonna, we've got to be ready. So here is the transmission electron microscope view of the herpes viruses. See them scattered through. You can appreciate that. Closer look. So with herpes simplex virus, asymptomatic, mild, can be fatal. Okay, if it disseminates, disseminated disease is seen in compromised patients. So if what? You suppress your your immune system to the point where these herpes viruses kind of come back out with a vengeance kind of thing. Severe burn patients, leukemia patients, transplant patients, inherited immunodeficiencies, anything from SCID to Weisskott-Aldrich that we've covered in immuno last semester. The site of infection, pretty familiar with the skin, especially lips and the genitals. Mucous membranes that can be inside the oral cavity, urogenital tract, be in the eyes, be in the central nervous system. And that's when we end up with some major problems. If it ventures into there, it goes into the central nervous system and gets around the brain. Lesions, fluid-filled vesicles, which coalesce or creep to form cold sores. That's what we're used to seeing, and we've got pictures to show. Primary infection, disease following initial exposure. So how do we acquire it? Direct contact with secretions containing the virus. So this one should be called the kissing virus, right? But it's not. But one of them is, right? One that's coming up. If it reoccurs after the latent infection, usually attributed to fatigue, stress, menses, fever, trauma, exposure to the sun. Oh no, we're really gonna, or cold. Okay, lesions reoccur. Disease usually appear at the same site with each episode. So it is that here it is again kind of thing, right? That cold sore that hits on the right lower lip or the right upper lip, there it pops up once again, and that was the initial site of infection. The host immune status and prior infection with different serotypes affect the extent of infection. So let's take the serotypes. Let's differentiate those into 1 and 2. 1, more than 3.7 billion people, 67% of the world's population under the age of 50 have been infected with herpes simplex virus number 1, according to the World Health Organization. It's one of the most common human pathogens, affecting between 50 to 90% of the people worldwide. Some of you are sitting there going, well, I wouldn't have herpes, right? Because I'm in the high income country and I don't become infected when I'm a child because I was in better hygiene and living conditions. But you're instead at risk of contracting it generally through oral sex after they become sexually active. Right? Genital cases of herpes simplex 1 infection are on the rise. Some 140 million people from 15 to 49 are infected with genital herpes simplex virus 1. Americans, Europeans, Western Pacific. It's primarily transmitted by oral contact, and in most cases cause oral labial herpes or cold sores around the mouth. The new estimates highlight the fact that herpes 1 is also an important cause of genital herpes. It's responsible for the majority of cutaneous, which means above the waist. Primary oral infections are self-limiting, associated with rhinitis, pharyngitis, tonsillitis. We can go actually into one called severe acute gingivostomatitis, all inside the mouth, around the teeth. All of these syndromes are associated with fever and long periods of viral shedding. So, approximately 50% of the young adults have recurrent oral herpes called cold sores, most often occurring in the mucocutaneous junction of the lips. How do we know it's a cold sore? Because there's tingling, burning, and itching. Virus can be isolated almost up to 90% of the early lesions, but about after 4 days, they're negative. The duration of shedding is 3 to 5. So pictures, I think we're all familiar. Not so much of this kind of breakout, but definitely that one. Cold sore on the outer lip. Close up for you. A little worse, moving into the oral pharyngeal, the tongue starting to be affected there, lower lip, inside the mouth. Back of the throat. Here's an awful picture. It looks like around the eyes. And this is called herpetic witlow, lesion on the fingers or thumb, caused by either 1 or 2 during primary infection. It's usually seen in children, young adults. It tends to co-occur with the gingivostomatitis. Oral secretions are the source of infection. So basically what the child's done is infected their hand by having the virus shedding around their mouth, in their mouth, either sucking on their thumb, right, and coming into contact with the secretions and actually infecting their finger. So you see here, this is the herpetic witlow. So we got it, breakout around the mouth, in the mouth, and then sucking on our finger, we ended up getting finger infected. So the big thing to worry about with simplex 1 is herpes encephalitis, because it rapidly progresses to severe fatal encephalitis. Mortality rates over 60 to 80%. Less than 10% result in survival without sequelae, which means if you do survive, you've got some problems. Acyclovir may reduce the mortality down. So if you suspected a viral encephalitis, right? So that's where we come in, just so y'all know, in micro, right? What happens? We check the cerebral spinal fluid. The reason it's vital that we don't see, if we suspect there is an encephalitis case and we don't see or detect bacteria, right? Bacteria in the cerebral spinal fluid, that's key to the doc to go down the road of thinking of viral. Okay, so that's very important that we handle the cerebral spinal fluid in a way. And I heard y'all are getting some fluids next week for body fluids, right? So we do the same thing. We detect, we look, right? The reason we look for glucose and protein levels, the reason we do cultures, The reason we do staining, gram stain of it, just to see if there's already bacteria there. The reason it needs to be a really good, the reason we do the third tube or fourth tube for culturing is because we don't want any normal flora down there, right? We want a really clean cerebral spinal fluid. Because if the doctor suspects viral, then maybe go on this path of let's get an antiviral on board just to make sure. So I don't know how we've lost our, from first semester we've lost our, right? Moms and dads. So when you become a mom and dad, because I know 99% of you don't have kids yet, you may run into this. You may run into, hey, nobody hugs my kid, right? Nobody's going to touch the baby. So if your in-laws start to complain about why, right, the grandparents want to know why, then you can share this story that you learned today, which is an Iowa couple is now urging new parents to be cautious of who touches, kisses, and interacts with your babies. We got a 3-week-old daughter died of a viral disease, likely passed through someone's kiss. All right, everybody wants to kiss the baby. Everybody wants to hold the baby, right? So they welcomed a baby girl July 1st, a week ahead of their wedding, but just 2 hours after the couple traded vows, which would have been, they had a baby girl, 3 weeks later, she started having trouble breathing, her organs started to fail, and they rushed her to the hospital, and they learned she had contracted herpes simplex virus number 1 meningitis. Both parents tested negative. Said it's likely disease came from someone who visited the child, touched her, and then she touched her mouth with her hand. Right? According to the pediatrician, viral meningitis is transmitted through close casual contact. It's so rare for a newborn to come in contact with the virus, but not typical that it develops into meningitis. So keep that in your memory, write it down. And when you decide you want to make sure that you limit the contact with your newborn, you've got reason to now. The first 2 months after a child is born is very critical. The virus can rapidly spread, cause illness to newborns. They repeated and said, don't let anyone come to visit them. Make sure they're constantly washing their hands. Don't let people kiss your baby. Make sure they ask before they pick up your baby. All the things we know about not risking meningitis. When simplex 1 disseminates, it can do that with immunocompromised individuals, such as our leukemia patient, and you've already had your leukemia, right, Heme 1. B-cell chronic lymphocytic leukemia, otherwise known as BCLL, also known as chronic lymphoid leukemia. It is a common type of leukemia. And we're going to show you a picture of a patient who's suffering from chronic, which way did y'all learn it? Chronic lymphocytic or chronic lymphoid? I'm asking. Have you ever heard of CLL?
I've always said lymphocytic.
Okay, so chronic lymphocytic leukemia. So here's our warning, and here is a patient with herpes simplex number 1 disseminated due to her leukemia. All right, simplex number 2. It is the primary cause of genital herpes. So 80 to 90% of the primary genital herpes are caused by simplex virus 2. As with 1, the primary infection is the most severe, accompanied by fever, longer duration viral shedding, and also less severe in people with previous 1 infections. So most of us have 1, right? So kind of protects us from number 2, as far as not showing itself as bad. Recurrences are frequent and may be asymptomatic in the women population. Most lesions are vulvar, but may be cervical, therefore go unnoticed. So the virus may be shed from the cervix between recurrences. So some pictures of some blisters, ulcers. Meningoencephalitis due to type 2s is seen in the immunosuppressed patient, including neonates. So this can, right? Neonate, baby, has to come through the birth canal. Doctor call again, see an active lesion, examination, may want to go with a C-section, right? To keep the baby from having to go through the birth canal that is severely infected. Increased risk once you have herpes simplex 2. There's clear evidence increased risk of cervical carcinoma in patients infected with genital herpes because the ulcerative lesions facilitate human papillomavirus infection. So you help set up the human papilloma, which we'll cover later. So any genital ulceration is not good. Neonates. So laboratory diagnosing, specimen, vesicular fluid or scrapings from the lesion, do throat swabs, conjunctival scrapings, do tissue studies with lung, brain, and liver, and spinal fluid. We can also do a direct exam, staining, looking for giant cells, and we'll see those in just a minute. We'll see the gympsum and papinicola stain with the giant cells and what those look like. Immunofluorescent, direct fluorescent antibody testing. Monoclonal antibodies allow differentiation between 1 and 2. So we probably have a antibody strip, comes through, has a line, pops up for 1, a line pops up for 2, makes it real easy. So here is the herpes simplex virus with the giant cell, histiocytes picking up multinucleated giant cells. All right, that's herpes simplex virus 1 and 2. Questions? Good. So here we have varicella Zoster virus, and this is chickenpox. And do I need to tell my chickenpox story? Y'all heard the chickenpox story, right? Freshman year in high school, about this time, ended up with chickenpox. So hopefully you didn't have it in 9th grade, but I did. I hadn't told that story on there. So. Are y'all just playing with me so I tell the story, or you already heard it? Really? Y'all hadn't heard my chickenpox story? Yeah, I was. No, we don't have time. We'll save it for lab. All right. So varicella, chickenpox, varicella, vesicular lesions. You break out in blisters. Still have scars. Face, chest, but everywhere. Arms, legs, but very itchy, very scratchy. Calamine lotion becomes your favorite pink stuff because I was coated in it most of the time for the week I was outbreak. But yeah, I was running fever, went to play baseball, played center field, Pine Bluff. I was the only one on the bus freezing in the spring day, didn't know why. Had blister on my back during study hall, didn't know what that was. Ended up with chickenpox. Yeah, football coach's son had it, gave it to everybody that wasn't already sensitized to it. Shingles is the zoster. It reappears, lesions over areas of the nerve ganglion. So you usually see this on a back, kind of like right through here. Usually it's the path of the nerve ganglion that it reappears in. Very painful. But there are vaccines, right? We have varicella vaccine for children now, and we have shingles vaccines for the elderly. Say elderly now, I'm getting there, right? So anyway, probably for everybody over 60. Not there yet. Varicella vaccine appears to be effective at preventing chickenpox, but has no or few side effects. The thing that we don't know here is the length of protection. Just like you've heard from COVID vaccine, same thing with varicella. Does it give a lifelong protection for the kids, or is it going to wear down? And the reason I know that, I think I did tell you the story of my daughter who had varicella vaccine, ended up with shingles at a very young age. Okay? So very scary in the immuno, oh my gosh, she doesn't have an immune system, right? And doctor assured me that she has a very good immune system now because she's been exposed several times. Like she had the vaccine, she got exposed to chickenpox sometime, and then it's already broke out in the zoster reappearance. So she definitely should have antibodies built up. But that's when I learned that the vaccine doesn't have a time of protection. So you could see chickenpox break out later in life. Like me in the 9th grade. There was no vaccine when I broke out in 9th grade. In children under 10 years old, causes a mild disease. I was 14, 15, somewhere in there. It's very severe disease. I ran a very high fever. In adults, the symptoms are more severe. I don't think I had encephalitis, but I did get admitted to the hospital. And I did survive, so it wasn't fatal. The lesions first appear on the trunk or the scalp, because I had this 104 fever plus, and finally the next day I had a blister appear on my chest. So that's how they knew it was chickenpox. And then they popped up everywhere after that, and they start popping and crusting and causing scarring. So it's almost like a smallpox lesion. But definitely some pictures here. That's more what mine looked like, just random blisters all over my trunk, chest, back, face. If you hadn't had it and actually seen it. Very bad on the legs there. Mine wasn't that bad. Wasn't that bad either. That might have been how my back looked. I don't know. That was more look like me there. And I don't remember anybody taking pictures of me when I had it, so I wish they did, so I could show pictures of mine. All right, disease may be severe or fatal in children with leukemia, transplant recipients. Congenital varicella may be associated with severe fatal infection. Here's pneumonia. Here's chickenpox with leukemia. It looks similar to the herpes with leukemia. Shingles is a reactivation, occurs 1 to 2% of those infected. So not a large number of people, but if you know somebody that has had reactivation, it's one of those that comes back. It's not one time. So extremely painful. Occurs most common after you're over 60. As your immune system decreases is what they think, and it decides to reactivate. So we can do material from the lesion itself, because that's going to contain any blister still contains the virus. So the varicella is in the chickenpox fluid. So if you're popping and going, oh, let me pop some of those, right? You can definitely infect if you hadn't been infected before. Direct exam with direct fluorescent antibody. And that brings us to cytomegalovirus as we're running low on time. All right. We have about 4 minutes. Let's see how far we go. So CMV, because we hadn't even got to Epstein-Barr, so I feel like we can do cytomegalovirus and then we'll call it a day. Pick back up. Congenital infection, most infections are asymptomatic. Intrauterine infection, that's where we're worried most. Children born to immune mothers, a woman who possesses antibody from a previous infection. Symptomatic infection, cytomegalovirus inclusion disease. So what's the transmission? Intrauterine infection associated with primary cytomegalovirus infection of a non-immune mother. So we can have congenital infection, but this symptomatic infection is where the non-immune mother passes it to the non-immune baby. Okay, symptoms are jaundice, hepatosplenomegaly, hemorrhaging, central nervous system, eye problems, hearing loss, mental retardation, or even stillbirth. You can also have perinatal infection after birth within the first few days, and we see that with breast milk. Most perinatal cytomegalovirus infections are asymptomatic. This would be a currently infected mom giving it to an immune baby, a non-immune baby. Most of the time, almost all of us are infected. 60 to 90% of adults possess antibody to cytomegalovirus with no evidence of infection. That's us. That's you. Pretty much. You've already been exposed some way, somehow. A mononucleosis-like syndrome can happen if it's a young adult. Sore throat, lymphadenopathy, splenomegaly is rare. And how did we get it? Close contact with an infected person, shedding the virus in their urine, nasal secretions, but also maybe through sexual contact, cervical secretions, semen. Highest concentration in the body occurs in semen. It's been transmitted through blood transfusion. This is where we brought up with Dr. Walls' class. An infected donor who is asymptomatic. Remember, the virus is in the lymphocytes. We hope that we don't transmit that, but it's mixed in, right? And we have to really worry about our transplant patients, our AIDS patients, and have severe disease, which may be fatal as a result of further suppression of their immune system, resulting in superinfections with the virus, association with prolonged fever, pneumonitis, hepatitis, leukemia. And if we have an immunocompromised patient, CMV infection may be a result of primary infection, reactivation, latent infection, viral DNA is incorporated in the DNA of the lymphoid cells. Small percentage of lymphocytes release small amounts of virus, which supports replication and allows persistence of the infection. If we transfuse blood with CMV, it leads to a prolonged fever, hepatitis, and atypical lymphocytosis, hence the term mononucleosis. Lab diagnosis, urine. Don't centrifuge it. And what we want to look for with direct exam is an owl's eye. Okay, so these big cells are found in the urine. They have inclusions of the CMV virus itself. And there it is. So I want to leave you with that look of the owl's eyes. All right, we'll stop there. We'll finish up Epstein-Barr, and some more herpes viruses. We'll stop the share, stop the recording, lecture. See y'all later.